So this is just the outline agenda. We're going to start with a very short presentation about disability worsening in early MS. And then Sarah Roderick, who's a specialist nurse, is going to discuss, I think, sometimes very difficult conversations we have with people we see, and particularly about the concept of progression and how one presents that to our patients. And then discussing a couple of case studies with Sarah, myself, and George from Shift MS. Basic objectives, really this is focused on disability worsening in early MS, and I think it's to try and get to a much more realistic concept of disability worsening in MS and what we actually see rather than perhaps what the textbooks tell us that we see. Understanding the patient's perspective on this, and also discussions about how you start those conversations around progression. So this is a traditional concept of disability, the famed EDSS, which I'm hoping everyone has some knowledge of in terms of the audience. It's basically a non-linear scale, so patients don't spend equal lengths of time on these different subsets, starting at 0 with a completely normal examination and being symptom-free. So people who've got a diagnosis, but perhaps have made very good and complete recoveries from their relapses, and then progressing through different ways and different times between the individual steps. The important ones to look at are between 0 and 4. So up to 4, people still technically have a full range of mobility. So the walking limitation, but still ambulant without walking aid, starts at 4. The next step, which is of importance, is a EDSS 6, which is the requirement for a walking aid. Initially unilateral, usually with one stick, EDSS 6, and the next main step is at EDSS 7, where effectively the person with MS is becoming confined to a wheelchair. And that's obviously an important marker in terms of eligibility of disease-modifying therapies. Finally, as it goes to increasing disability, becoming bedridden at 9, and obviously at 10, that represents death. And so that's a basic concept. Important things to note are people do not spend equal lengths of time at those steps. And also you can see how mobility driven the EDSS is. Level of mobility, particularly when one goes past EDSS 4, really dictates your EDSS score. And this is the traditional subtype of MS, which we sort of all read about. The concept of benign MS is basically people who pick up minimal disability, usually classified as EDSS less than 3 or at 3, so fully ambulant still over at least 15 years. What we then realize that ignores all the other potential symptoms that don't rate on the EDSS, particularly things like fatigue, cognition, and so how truly benign is that? Relapsing remitting MS, where there is this relapse-driven progression in terms of increase in disability, but you can see there's still clear remission, if not with complete remission, between each relapse. Now, this was the majority, like subtype of people with MS being diagnosed, about 85–90% of people. But as you can see, there is this concept of complete stability between relapses and a good recovery from really most or all relapse. And how well does that really reflect the people that you see in clinic? Then secondary progressive MS, roughly as time goes on, 40–50% of our patients who are classified initially at relapse remitting will get to what turns secondary progression after 10–20 years. You can see the initial relapse remitting phase, but then the progression occurring after a variable period of time. This is a common scenario, but it doesn't reflect progression that happens earlier than that, but relapse is still happening. So it seems a very clear stepwise change between relapsing remission and secondary progression. And again, how well does that really reflect what we see in our patients? And finally, 10–15% of people with primary progression. So this progression from outset, and this clearly is a phenotype of some people, a minority, as said, although very rarely, occasionally, people can have superimposed relapses within that. And so although useful concepts and certainly concepts that drive disease-modifying therapy, there are clear flaws, and I think we can all sort of appreciate that when we see people with MS. Relapses obviously occur in the majority of people on and can pick up disability, and so this is a concept of relapse-associated worsening. We often will see stability after a relapse or even some improvement back towards baseline. And so this is the graph on the left side with the relapse occurring and the EDSS rising with the disability associated with the relapse, and then either a full or partial improvement or change which is maintained on the EDSS, so relapse associated worsening or RAW. But I think what that ignores and what we see really quite commonly in people, even at the earlier stages of MS, is what's happening on the right-hand side graph. So the relapse occurring, good recovery, but without perceptible new clear demarcated relapse, increasing EDSS. We see a patient perhaps after 6 to 12 months after their initial diagnosis, the person will complain of certain symptoms, whether it be fatigue or mobility related, balance, and so forth. And so the EDSS changes, but there is no clear relapse is that the patient can report to you. So how does one classify this? Well, you could say that at some stage there was a relapse in amongst there. It's difficult to know exactly the timescale, but we recognize that this is a more of a grumbling type phenomena or a smoldering type phenomenon that has been given a further name. And this really is what we're talking about, this concept of PIRA, progression independent of relapse activity. It's certainly too early, I would suggest, to give this the secondary progressive label, because quite often when we do MRI scans, we may see new inflammatory activity. So this is not a neurodegenerative problem, but it isn't a clear relapse remission or raw phenomenon. So this is accrued disability, which is occurring independent of relapse. So PIRA, the name given. So this is data collected from the MS-No database, which is basically a collection of 5,000 patients across 22 trials, looking at natural history, which has been collected up to 50 years now from extension studies. The advantage of this really is that it reflects, if you like, a better treated or a population that you will see in clinic and contain all phenotypes of MS. This gives us like a more real-world sort of view as to how people actually behave in different subtypes of MS. And if you look at the first graph or table on the left-hand side, this is the remitting cohort. You see some numbers to over 24,000 people. What you see in the immediate left side is patients with relapse and the associated in blue, the smaller figure on the smaller bars below, relapse associated worsening. And then what you're seeing in the pale green on the right side of that initial figure is the associated non-relapse aspect of this. And the purple color, the PIRA, the sustained disability worsening that is occurring outside of relapse. And if you just make out a darker between the blue and purple, it suggests a mixture of both PIRA and also a mixture of disability occurring both due to relapse and independent relapse. And what this clearly illustrates is that a significant amount, even in relapsing and remitting MS, of disability is not associated with relapse and actually could be attributed to this concept of independent relapse activity. As you'd expect with the progressive subtypes, both secondary progressive and primary progressive, the amount of disability associated independent of relapse activity increases. There is still relapse activity, particularly in the secondary progressive. We all know this concept of active secondary progression, and this can cause disability, as you again in the middle figure, that blue bar graph, but a more significant proportion being associated with PIRA independent of research of relapse activity. And as you would expect, this figure for primary progressive people increases again independent of relapse activity. So it's really a clear, even really from the early relapse remitting stage, a significant amount of disability progression being independent of relapse activity. Obviously, clear association with relapse activity, particularly in early MS, but a significant amount not associated with that. And that really, I think, should focus our minds on treating the whole aspect of what we're seeing in front of us. And so this looks at the impact of treatment of disability worsening. This is, I think, becoming increasingly relevant as the number of treatments and the indications start to increase. As you'd expect, treating somebody with relapsing remitting MS doesn't make a particular comment about which disease therapies are used. It's a mixture of several. This will give rise to a difference between actively treated relapsing remitting MS top graph compared to placebo treatment. And as you expect, relapses on the placebo treated cohorts being mediating more of the disease activity. But as you can see, even in those treated, we're still seeing progression independent of relapse activity in the relapse remitting group. And the suggestion would be, particularly this is of a number of disease, particularly disease modifying therapies at the more moderate end of disease activity, the importance of treating the patient adequately. Progression, even again in the treated cohort, would be people who predominantly would be active secondary progression who treated with beta interferons. There's relapses associated with worsening, but also significant amount of progression independent of relapse activity. And again, is also the case with prime progressive MS, and as you would expect, less of a difference actively placebo treated, as there's obviously less relapse activity in this cohort. But again, what I would take away from this is that even actively treated people in cohort, perhaps on lesser effective disease-modifying therapies, there is relapse associated worsening, but also a significant amount of independent relapse activity progression. Take from this is that progression occurs early. It occurs in all so-called subtypes of multiple sclerosis and continues even with disease-modifying therapy, particularly the more moderately effective disease-modifying therapies. The predominant disease-modifying therapy used in this cohort were the injectable, moderately efficacious therapies. It demonstrates the importance of early treatment because progression occurs early, independent of relapse activity, and therefore may be less reversible, and the use of more highly efficacious disease-modifying therapies. I think what we'll do is, I think there's probably a problem with moving the size of this presentation, but I think that presentation has come to an end anyway, so if we can move on to Sarah's presentation now about progression and the conversations we have with our patients.
So I'm Sarah Roderick, and I'm a multiple sclerosis specialist nurse in Huntingdonshire. I'm a community specialist nurse, and I'm going to do a session on when and how to discuss progression with patients. My disclaimers are at the bottom of the screen. Okay. So truth and honesty is important throughout the relationship with our patients. I see our work as an alliance, a reciprocal relationship. I talk to my patients about our aim to work collaboratively. We're part of their team. It's important to be able to offer reviews as needed, and they should know when to make contact with the service between planned reviews if there is a need for the person with MS. And I'll talk about red flags in more detail later on in the session. People with MS need the opportunity to ask questions and make sense of what is happening to them. Education is important from diagnosis and throughout the disease progression. I talk to my patients about the main focus being on their quality of life and managing symptoms well. We need to go at the patient's own pace, but it's necessary that they understand what MS is and how it may affect them as an individual. There needs to be a conversation about disease-modifying treatments and how they may slow down the progression of their MS. This is relevant even if somebody may be progressing. MS isn't simple. People don't just go from one type of MS to another. There's no real distinction. It's not easy to label, as Wakar was saying. People need to understand what measures they can do to help keep themselves healthy, both physically and mentally. And they need to recognise what a relapse is and how to manage that. And by giving our patients red flags, they then understand when they need to seek help or support. They know what to do, which in turn helps them to self-manage, which is the aim for everybody, really. Our patients attend busy clinics often, and so encourage them to prioritise what they might want to speak to the clinician about when they arrive. Some places may send out pre-appointment questionnaires that will help to guide the consultation. After meeting my patient, I'll always start with, is there anything specific that you'd like to talk about? Again, it's about giving the person with MS a voice. We need to know our patient, so we need to understand how we can help them. I find that some patients will start to notice that they're progressing and will remark on how bad a specific symptom is. By looking back at my previous assessment, we can compare, and often the symptom may be the same as it was the time before, but it's just more obvious to them now. And this can be reassuring that progression might be slower than they were expecting. And by asking the person with MS where they feel they're at, it helps to guide where your conversation might be going. So a full holistic assessment is important to pick up small changes in symptoms. We might ask questions like, can you multitask? How often do you need to get up at night time to pass urine? What are you like on the stairs? Can you walk as far as you need to? Are there foods that you struggle with? How has work been? There's a fear factor and uncertainty to MS. People may have this fear of ending up in a wheelchair, but they may not want to ask us. And so it's important to explain to our patients that we often work in hindsight. We don't know how their MS will affect them in the future. People may sometimes drop in small cues rather than make big statements, and it's important we pick up on these and not gloss over them. Try to explore what they mean. What are they thinking? Hope is very important. Explaining what you may not do, that you may not be able to do things like you used to, but you can still do things, can be reassuring. There are still ways of improving life through rehab and adjustment. And in our service, we're lucky to see that our patients from diagnosis, we see our patients from diagnosis and we don't discharge them. If that's not the case in the service that you work in, it's important to make sure that they know who they need to contact if they are struggling. It's useful to let them know about different members of the MDT and when they might ask for referrals to them. For example, when they might need to ask for community OT, for example, for possible adjustments in the house. This is a lengthy process and something that can't be left until crisis. Other important contacts for the person with MS, if they're discharged from your service, might be the MS Trust or the MS Society, the phone lines that they offer, Shift MS, MS therapy centres, or it may be that an advanced MS nurse is needed in your area. So this list here is not limited. I'll normally give specific ones to my patients as we get to know them and how their MS specifically affects them. But the relapse is an obvious one. We'll talk to them about how to recognise the relapse and management of it from diagnosis. The other red flags on this list are times when people might be finding that their MS is impacting on their life. And if we don't know about it, we can't try. If we know about it, we can try to help them to find strategies. As an example, I might tell people at diagnosis that if they do or when they do struggle at work and feel that they need to stop or cut their hours, to try speaking to us first. I'll talk about their rights and reasonable adjustments and support that OTs, for example, can give. And it's quite common for people to find that their life is closing in, that they can't get out as often as they used to, or their friends aren't visiting as often. And we can perhaps help them to look at ways around this. Wakar mentioned the EDSS, and I'm not really going to mention much on this slide, other than to say that I can see some potential in smart watches, and maybe, you know, this is something in the future that will help people to measure their MS, and perhaps you know, it's a useful thing to look at. So acceptance is a process. I try to introduce the idea over time with my patient about how if they can learn to accept their MS and see it as part of them rather than fighting it, they may find that their quality of life improves and that their life opens up to other possibilities. It's not an easy process, and it can be slow and difficult, and each step is almost like a bereavement to themselves and to their families. I may ask if they've thought of an alternative, for example, if they couldn't use the stairs because of infection, or if they became acutely unwell. And it's about opening up the conversation and helping them to think about what the future might look like for them. And Life Threads model is a new model that I've just recently learnt about in bridges training that we're doing at work. I think it fits well for people with MS as they start to progress. The thread is a metaphor for different parts of ourselves. So as an example, Sarah the mum, Sarah the wife, Sarah the nurse, Sarah the cleaner, Sarah the swimmer, etc. And as disability increases, people start to lose parts of themselves, but it is possible to join some of those threads back together through rehabilitation and setting different goals. So just to conclude, what I've found in my practice is that by being available and working with my patient when they're struggling or when their MS changes, help them through that difficulty so that they find strategies and can learn to self-manage and better function on their own. But they know that where they need to come to, or when they need to come to us if they need further support. And there are my references.
Thank you, Sarah. That's really, really good. I think I'd be really grateful if you stay for the next part and to talk about some of the issues that you've mentioned. I'm also going to introduce George Pepper from Shift MS, which I think is a hugely helpful charity and website, which I direct all my patients to, in addition, obviously, to the standard ones. So, George, welcome. I'd be really interested in your thoughts about the conversations about progression. And people's concepts of progression. What do you see from your experience?
Well, firstly, yeah, thanks for having me, and yeah, fascinating to hear both your talks from your different perspectives. I think the subject of progression is clearly hugely important in MS, and I think it's become quite confusing for people living with MS what we mean by progression. And I think this isn't helped by the labels that are put on MS. So that's just something which I think we're all aware of, but I think it's good. It's worth remembering that the types of relapsing, remitting, secondary progressive, etc. I think give people sometimes the false understanding of what progression actually means in MS. Beyond that, I was kind of nodding throughout Sarah's presentation, and I do think that the early conversations that you have with your patients are unbelievably influential to how they live their life, to how they see their MS. And I don't think that can be overstated. And I think there's two things happening here which are kind of drawing against each other. One is that these are vulnerable people. And when you're giving a diagnosis of MS, this is a tough thing to hear. And I understand that it must be incredibly challenging to be the healthcare professional who delivers that information. But at the same time, I think the importance of being clear and open about the severity of the condition they're being diagnosed with from very early on, not necessarily the first conversation, but in the first kind of the weeks after diagnosis, is important. And I just don't. I'd love to hear a counter view, but if I see the pros of understanding, following a diagnosis that I have a condition which is unpredictable, which is debilitating, which I'll have for the rest of my life, and importantly for this particular meeting, is progressive. What that does to me is it informs me not only on the severity of the condition, but also, like when I was diagnosed and I understood those words, it made me immediately kind of sit up and take notice and understand what I could do to make a difference. I then, over time, understood that modifications with my own lifestyle, early access to effective DMTs, can genuinely influence my long-term outcomes. And I think it's very difficult to expect a patient to be able to make a proactive decision about changing their lifestyle or about going on a high efficacy treatment, for example, without understanding the severity of the diagnosis.
I think it's such a difficult balance, isn't it, to get between, obviously, at the very early stage of a diagnosis, you want to offer hope and optimism, but also it's about getting across honesty and risk, and also the importance about treatment and lifestyle, as you say. And it is a fine balance to get the degrees of optimism and realism right in people, and it's different for different people.
For sure, and it's an almighty challenge. So none of what I'm saying today is a criticism on healthcare professionals. It's more an acknowledgement of the importance of those conversations that you have at the very beginning. Because trust me, when I speak to other people with MS, which I do on a daily basis, the amount of times that people, even many, I'm 17 years from my diagnosis, and I remember that appointment very clearly, and many people do. So those appointments live long in the memory. And I think it's crucial that the messaging that you share as healthcare professionals is on point. And there was a balance, absolutely, Waka, I agree. And a piece of work that we did at Shift.MS in collaboration with Gavin Giovannoni and his team at BARS, I think it's about 18 months ago, and we put a survey out to understand about the trauma that MSs feel following diagnosis. And the results we got back was, it was harrowing in a way. We had over 1,000 people respond, and around 60% of the people who did respond shared about how they've experienced symptoms associated with post-traumatic stress disorder. And that's almost 60% of the 1,000 people that responded. That's significant. And 154 of whom had received a formal diagnosis of post-traumatic stress. So this is considerable, and there's clearly more work. Well, I say clearly, and you can disagree, but it seems there's a lot more work for us to understand what is the negative impact that's being caused at diagnosis, how can we alleviate that, while at the same time giving people the information that they need to make the right decisions for their long-term health.
I think that's really important, and it's very impactful what you say there. Sarah, perhaps I don't know if you want to add anything there about what you see as a specialist nurse and the initial conversations perhaps you have, both a diagnosis or if the person is concerned that they're progressing.
From my experience, I would agree with George in that the patients that we have who perhaps have not had a good experience of being diagnosed by letter or were not expecting a diagnosis of MS when they went in and came out with a diagnosis, so it was a complete shock to them. I find they need a lot of support initially, and they may need to see us quite a lot to try and unpick that and help them to understand it a lot better, just so that they can move on and start understanding what's happening to them. They almost go into shock, and it's a huge panic for people and for their families. So I think diagnosis and how it's given is really important for people.
I completely agree. And I think it's really important, I think, when we're giving diagnoses and when it's the first or follow-up visits, because often people then have gone through, they may have very strongly suspect the diagnosis and be quite aware of these subtypes which are there available when you go on the internet and so forth. And I actually think it's, and I'm very upfront about this, and I say I don't believe in these subtypes, and I think actually there is, and I think you mentioned in your presentation, Sarah, getting across actually the fluidity between different subtypes, and actually people can, depending on the time, can exhibit, say, a relapse, or other times outside of relapse, what could be considered progression, but actually being upfront about it, actually testing out of it, because the concept is, if you look at this, progressing, that's it. This is an inevitable decline. Is going to help, and it's irreversible. I think it's really personally, obviously interested in colleagues and also on the chat and the Q&A. Please put questions in the Q&A. What people's things are to actually try and nip that in the bud and say actually progression and this concept of PIRA happens early. If you're experiencing it, let us know, because we can actually do something about this. It is not a terminal decline or an inevitable decline, I should say. Just illustrate a couple of cases just to try and do this, and we'll have a further discussion. So, this was the reason I put this up is a 38-year-old who has really quite bad MS. So 1 year history, worsening on the left side, coordination becoming a problem. But it was continual. You know, you speak to him and you're trying to discern relapses. So I've never felt stable. I've never stabilized. I've definitely not improved. I'm getting worse. And obviously it takes time, particularly in the pandemic, but he eventually got into medicine because he'd had a fall, he had a scan, so it showed changes. And of note, you can see the clear MRI changes, the enhancing lesion, the lumbar puncture was done unfound. He was referred to neurology, was seen in a general neurology clinic, and because of this history given of things never improved, it was continuing to worsen. You know, I'm saying this is wrong, but given a diagnosis of primary progressive MS, and the whole world fell apart when you look at that. It was referred to specialist clinic. This is on the days where ocrelizumab is available, and so essentially, do I think ocrelizumab would be appropriate? Any brief thoughts, George, Sarah, from this?
So from my point of view, we work with a general neurologist, and often when we see the patient and then do a full assessment and start talking to them, they will, historically, they will find events that might have happened to them that they didn't realize was relevant to their MS, which would make a difference to this diagnosis if you were able to unpick that a bit more. I'm not sure that I would go for primary progressive MS. I don't know. It's hard to know, I guess. I don't work in a DMT clinic. That's the other important thing as well.
But yeah, and just for this work,
George, what your feeling is in terms of being given a diagnosis of primary progressive MS and how impactful it is on people, not only getting the diagnosis, but also told you're progressing from outset.
Firstly, I'd be, if someone close to me said that they received a diagnosis of the type of MS from a general neurology clinic, I'd ask them to re-question that straight away. I think it's really important that they're seen by an MS specialist as soon as possible, if that is possible. I mean, there's no doubt receiving a diagnosis of primary progressive MS, for an individual, that feels like once they understand what that means, I think it's the worst of the diagnosis, right? So it's not a good thing to hear. But also at the same time, like I agree with what you said earlier, these definitions of different subtypes of MS I think can be a distraction, because what do they actually mean? I mean, they're just there for these days. They're just there for access to treatment purposes, I believe. And really, if that person can still benefit from Ocrevus, to me that's the focus rather than the type of MS. It's what's the right treatment for them. And thankfully now, compared to 5 or 10 years ago, where there weren't options for that subset, at least there's some positivity.
So if we move on to the next slide. So, and I say it's a very good general neurologist who arranged for a further full MRI scan, which time before I saw the person. By that time, he'd worsened further. He'd DSS-4 to walk limitation, had an intermittent ophthalmoplegia, some cerebellar signs, and a mild vascular paraparesis, and there was a new brain cord lesion. And we'll move on to the next slide, because clearly, in my opinion, this is not prime progressive MS. So if we go on to the next slide. So even though there is progression and there is seemingly no clear demarcation of relapse remission, but this is inflammatory based, and that's the key thing in my opinion. We're seeing new lesions, multifocal new symptoms, signs, whereas in my opinion, what is progression is a degenerative process or predominantly degenerative process that could be mediated by underlying inflammation. It is predominantly in most people a gradually worsening spastic paraparesis, and this is clearly not happening in this gentleman. And so I revised diagnosis. I think this was a highly or res given the current nice currency. I don't like these terms, but this is an inflammatory process that's going on. And Ocrevus, ocrelizumab may be the right thing, but he also, I felt, had choices of all the other higher efficacy disease-modifying therapies. And really, the clear priority was to treat with an early high efficacy therapy given the rate of progression. So I adjusted the diagnosis and just put forward for all high efficacious relapse remitting therapies. Any comments on that, George or Sarah?
So from my side, and I'm not talking specifically about your case study necessarily, but from what I understand from your presentation, Waka, is it fair to say that you believe that all MS is progressive?
So I think what it's saying is that this comment about PIRA. So you could say it's difficult to know how much fits into relapse associated worsening or progression independent relapse. You could say this is all just one continued relapse, but I think the point would be that this is a continued inflammatory-led progression or process, and so should be treated with all offered with all higher efficacy disease-modifying therapies. But this is to illustrate a 44-year-old woman who was already on Tecfidera, clearly progressing, looking at the consequent EDSSs. So I'll just, if interest of time, just move on to the next slide. And so it's taken 3 years since the scan with no new changes. So with no discernible relapse and no change on MRI, even after discussion on MDT, effectively this is what was defined secondary progression, and you could just argue we should be taking her off dimethyl fumarate, but didn't really have any way to go in terms of additional disease-modifying therapy. Even Siponimod, before an important retake change, which Palantir will talk about further in her presentation, because we're not seeing evidence of new relapse or a change in MRI. And this was really the bind that we got us into with the initial criteria available for Siponimod. So any final comments to Sarah and George?
Yeah, just so briefly, we see on the site almost on a daily basis people coming onto the site who've perhaps been diagnosed for a number of years and will leave a post talking about how their MS is progressing, and this is a new thing for them. MS is progressing, and then we hear about the impact of that kind of secondary diagnosis when they may be told by the neurologist that they have secondary progressive MS, and what a hammer blow that is for them. And I do believe that we can alleviate some of the both the surprise and the trauma of that secondary diagnosis by just being clear from the start that MS is a degenerative progressive condition. And I think that just helps rather than this kind of, oh, I've suddenly got progressive MS, which I don't believe is the case. So I think we can really think about the language and how we communicate this with patients.
Sarah, do you have any, particularly about disease modifying therapy in this situation? Effectively, we're saying to the person that to stay on dimethyl fumarate, a medication that they've, and no criticism of dimethyl fumarate, it could be another DMT, but effectively an indication that they're progressing because we're not seeing visible relapses or MRI change, which the dimethyl fumarate may be masking, but the person is still progressing.
I didn't quite hear what you were saying, but I think going back to George's, I completely agree with what George was saying about that we do need to talk to our patients about progression from beginning all the way through. Really, it has to be part of that dialogue in a careful and at their pace as well. We have to be going at their pace, sensing when they want to have those discussions and when they don't want to have those discussions.
Thank you. Apologies if I'm not sure if there are sound issues at my end, but we'll draw this first part of the session to a close.